We are Group B1, and the topic we have chosen to focus on is dissociative disorders. To begin, I'm going to give you a brief overview of what we will be addressing today. We will look at the background of dissociative disorders, characteristics and symptoms, causes, examples in the media, non-medication therapy, treatment and interventions, and effective studies. We will begin with the background. What are dissociative disorders? Dissociative disorders is a type of mental disorder in the DSM-5. People who are diagnosed with dissociative disorders have previously experienced traumatic and stressful events. With dissociative disorders, an individual's mental functioning can be disrupted and problems with memory, identity, emotion, perception, and behavior, and sense of self occurs. Symptoms of the disorder can vary from mild to severe. Severe symptoms of dissociative disorder often interfere with personal life and work. Lastly, there are currently 3 types of dissociative disorders. They include dissociative amnesia, dissociative identity disorder, or DID, in which we'll be focusing on more in this presentation, and finally, depersonalization derealization disorder. We are going to begin with dissociative amnesia. This type of disorder was previously referred to as psychogenic amnesia. It involves a significant amount of memory loss of personal life and even their identity. Studies have demonstrated that dissociative amnesia was highly associated with stressful and traumatic events such as environmental or natural disasters. A subcategory of dissociative amnesia is dissociative fugue. Both dissociative amnesia and dissociative fugue are considered to be quite rare in the general population, with 1% of men and 2.6% of women being diagnosed with dissociative amnesia. In the event of an individual with dissociative fugue, they usually don't remember any of their personal information. Many of them usually end up at a new location and adopt a new identity instead. Now we're going to look at dissociative identity disorder, or DID. The disorder was previously commonly referred to as multiple personality disorder. It is because the individuals who are diagnosed with this disorder exhibit at least 2 or more alternate distinct personalities. These personalities may change with or without the awareness of the host, who is the original personality. Behaviors, memory, and thinking are completely different when the alters change. These alters may have different preferences in terms of clothing, food, and activities. There are usually memory gaps because each alter remembers certain events when they are in control of the host body. According to studies, DID is linked to childhood traumatic experiences, and 90% of the cases are directly related to any type of abuse. DID is rare, but it can occur at any age, and it is said that females have a higher rate of being diagnosed with it than males. Now we're going to look at depersonalization derealization disorder. These 2 disorders usually occur together. Individuals typically feel disconnected from their feelings, thoughts, body, and their environmental surroundings. It is said that the environmental and biological factors play an important role in these 2 disorders. Depersonalization and derealization disorders are quite common, with 50% of the population being diagnosed. Young people, especially those that are around the age of 16 years old, are more commonly diagnosed with the disorder. Studies have displayed that symptoms of these disorders are correlated to schizophrenia or dementia. Now we're going to look at specific characteristics and symptoms. The different signs and symptoms that may be present depend on the type of dissociative disorder a person has. Most common signs and symptoms include, but are not limited to, memory loss. This can happen for certain periods of time, people, events, and even personal information, a sense of being detached from yourself and your emotions, a blurred sense of identity, significant stress or problems in your relationship, work, or other important areas of your life, inability to cope well with emotional or professional stress, mental health problems such as depression, anxiety, and suicidal thoughts and behaviors. The specific disorders are more closely linked to specific symptoms. To begin, dissociative amnesia, the main symptom is memory loss. That's more severe than normal forgetfulness and can't be explained by a medical condition. You can't recall information about yourself or events and people in your life, especially from a traumatic time. Dissociative amnesia can be specific to events in a certain time, such as intense combat, or more rarely can involve a complete loss of memory about yourself. It may sometimes involve travel or confused wandering away from your life, also known as dissociative fugue. An episode of amnesia also occurs suddenly and may last minutes, hours, or rarely months or years. Dissociative identity disorder. This disorder is characterized by switching to alternate identities. You may feel the presence of 2 or more people talking or living inside your head, and you may feel as though you are possessed by other identities. Each identity may have a unique name, personal history, and characteristics, including obvious differences in voice, gender, mannerisms, and even such physical qualities as the need for eyeglasses. There are also differences in how familiar your identity is with the others. People with dissociative identity disorder typically also have dissociative amnesia and often dissociative fugue. Depersonalization derealization disorder. This involves an ongoing or episodic sense of detachment or being outside yourself, observing your actions, feelings, thoughts, and self from a distance as though you're watching a movie, which is depersonalization. Other people and things around you may be detached and foggy or dreamlike. Time may be slowed down or sped up, and the world may seem unreal, which is derealization. You may experience depersonalization, derealization, or both. Symptoms which can be profoundly distressing may last only a few moments or come and go over many years. Now let's talk about some of the causes for dissociative identity disorder. The first major cause of dissociative disorders is abuse. Abuse can either be emotional, physical, or sexual. According to the Cleveland Clinic, approximately 90% of dissociative identity disorder cases involve some sort of long-term abuse. The theory here is that if a person experiences a trauma, such as abuse, for extended periods of time, they may begin to dissociate from themselves in order to escape the distress they are experiencing. A second possible cause of dissociative disorders could be accidents. Other than the prolonged types of trauma mentioned in the last slide, this could be any short-term but intense trauma faced by an individual. An example of this could be a car accident. The individual who witnessed this kind of shock may begin to dissociate to escape the memories of what they saw. This is especially true if a life is lost or the person feels responsible for what happened. According to the Australian and New Zealand Journal of Psychiatry, the highest prevalence of dissociative identity disorder is in the emergency setting. Cause number 3 is natural disasters. These occurrences are similar to the accidents that we mentioned previously. Earthquakes, destructive storms, volcanoes, and floods are some examples that may lead to long-term trauma and PTSD. In these types of situations, people often lose their homes, pets, family members, and personal belongings that may be meaningful to them or are left with nothing. Dissociative cases seem to be even more prevalent in natural disaster influences where there is a high volume of loss of life or inability to rescue for long periods of time. In these situations, a person may try to separate from these feelings of loss, suffering, fear, or hopelessness by dissociating themselves and observing from the outside. The fourth cause may seem self-evident: war. It is already known that soldiers and individuals who experience combat firsthand are already at risk for conditions related to trauma, especially PTSD. But studies show that veterans can also struggle with dissociative disorders. Interestingly, PTSD and dissociative identity disorder have also been found to coexist in some instances, which is understandable as individuals want to escape the fears that they experienced in the past, which may lead to dissociation. Similarly, the civilians who are caught in the middle of these conflicts can experience dissociation that can lead to dissociative identity disorder. The fifth possible cause is loss of a loved one. This is a very specific type of trauma that would create an inner turmoil for anyone. It is difficult for everyone to handle the loss of someone close to them, but in situations such as loss due to violence or inability to cope, the escalation of that grief may lead to a person to dissociate and possibly develop one or more alternate identities to deal with the loss. This disorder can be even more likely if the loss occurred during an individual's childhood. The loss of a parent or caregiver can leave a child susceptible, afraid, or somehow victimized. Adults may become more prone to the development of dissociative identity disorder if they feel the circumstance of the death occurred as a direct result of their actions or behavior. Guilt can be a powerful source of dissociation, and a study from the Journal of Clinical Psychology indicates that guilt and shame can actually be predictors of dissociative behaviors. Finally, early trauma in a childhood is a cause of dissociative identity disorder. We have discussed trauma in depth and briefly touched on how trauma can be exacerbated if experienced at a young age. So now we're going to dive a little deeper into the age aspect. According to an article published in Psychology Today, children who experience trauma are susceptible to developing dissociative identity disorder because of their dependence on adults and their lowered ability to get away from all the previously mentioned causes. As a result, the only escape for these children is through dissociation, which can lead to the development of alternate identities. This specific trauma can be even further magnified if the source is someone the child trusts. The struggle between the need for trust and the need to escape can result in the child seeking refuge by creating another identity who doesn't feel the fear, anxiety, and pain. So the causes of dissociative identity disorder can be arranged into 6 categories: abuse, accidents, natural disasters, war, loss of a loved one, and trauma in early childhood. While each of these causes have different factors to it, they all share one similar aspect. Situations that cause trauma or intensely adverse feelings in a person can cause them to seek out a need to escape by creating an alternate identity. The identities they create are ones that do not have to feel the feelings of pain, anxiety, fear, and loss. Now we're going to look at how this disorder is portrayed in the media. The media plays a huge role in the depiction of dissociative identity disorder. Many articles can be found online that analyze various Hollywood movies and the negative ways that they depict individuals with DID. The movie Split got a lot of backlash from mental health professionals, people who live with dissociative identity disorder, news networks, and many others for depicting dissociative identity disorder as extremely violent, dangerous, and something to be feared. Oftentimes, these Hollywood blockbusters depict those with DID as violent, unstable people, which in reality, that is not always the case. In fact, according to an article from techtrauma.com, people with DID are more likely to be victimized by others than to victimize them, according to research. For example, very low rates of incarceration, convictions, or probations were found in the last 6 months among a sample of dissociative disorder patients in treatment. Now we're going to look at a preview for the movie Split.
Hey, pardon me, sir. I think you have the wrong car. What are we doing here? What the hell is going on?
I was sent to get you for a reason.
There's a flower on the pillows, a flower in the bathroom. Like, we're important.
The only chance we have is if all 3 of us go crazy on this guy.
Who is that? Maybe she can help us.
Don't worry. He's not allowed to touch you. He knows what you're here for. He listens to me. My name's Hedwig.
How old are you?
9.
I've never seen a case like this before. 23 identities live in Kevin's body.
Who are you? Help me get out of here, Hedwig.
You trying to trick me? I'm telling you. Aren't you the clever one?
An individual with multiple personalities can change their body chemistry with their thoughts.
Someone's coming for you.
Who's coming?
The beast.
There's a man here. He abducted us and he's going to kill me. We're meant for something. Something horrible.
The world will understand now. The beast is real.
We can clearly see that the person in this movie suffering from DID was made into something to be feared. Movies like Split or any other storyline involving someone suffering from a DID or other dissociative disorder portrayed in a dangerous or scary way are likely to increase stigma around these disorders. Young children who watch movies like these will unfortunately develop this negative outlook on these disorders. Now we will explore non-medication therapies, treatments, or interventions. There is no cure for dissociative identity disorder. However, there is long-term treatment that can assist and aid these conditions. The purpose and goal of treatment for dissociative disorders are to help the patient safety recall, process painful memories, develop coping skills, and to integrate the different identities into one functional person. Treatments range from psychotherapies and pharmacotherapy. Psychotherapies are cognitive behavioral therapy, dialectal behavioral therapy, and eye movement desensitization and reprocessing. Cognitive behavioral therapy, or CBT, is a short-term, problem-focused, and goal-oriented form of psychotherapy. It helps the patient develop the skills and strategies to cope with negative thinking and to stay healthy. CBT focuses on changing functional thinking patterns, feelings, and behaviors. Additionally, it helps the patients examine how they can make sense of what's happening around them and how these perceptions affect the way they feel. The goal of CBT is to reduce emotional problems by teaching people to identify distortions in their thinking, see thoughts as ideas about what's going on rather than facts, and look at situations from different viewpoints. Dialectical behavioral therapy, also known as DBT, is an evidence-based model of therapy developed by Marshall Linhan in 1980 to treat people with borderline personality disorder. It focuses on teaching coping skills to combat destructive urges, regulate emotions, and improve relationships while adding validation. DBT includes 4 behavioral skills that are taught, which are 2 acceptance-oriented skills, which are mindfulness and distress tolerance, and 2 change-oriented skills, which are interpersonal effectiveness and emotional regulation. There are 4 stages of treatment, which are defined by severity of behaviors. S1. The patient is miserable and their behavior is out of control. The goal of treatment is for the person to move on from being out of control to achieving behavioral control. S2. The patient feels that they are living a life of quiet desperation. The goals are to help them move on from a life of quiet desperation to one full of emotional experiencing. S3. The challenge is to learn to live such as to define life goals or to build self-respect. The goal is for the person to lead a life of ordinary happiness and unhappiness. S4. The goal is to find a deeper meaning through spiritual experience. Now we're going to look into eye movement desensitization and reprocessing. This psychotherapy is designed to alleviate the distress associated with traumatic memories, persistent nightmares, and flashbacks. It combines the CBT techniques of relearning thought patterns with visual stimulation exercises to assess traumatic memories and replace them with positive thoughts. Additionally, it directly focuses on the memory. It is intended to change the way memory is stored in the brain. Furthermore, the use of eye movement and other forms of rhythmic left-right stimulation, which patients focus on traumatic memory and simultaneously experience bilateral stimulation. This helps reduce the vividness and the emotion of the memory the patient has. Now we're going to look a little bit at pharmacotherapies. There is currently no medication that will treat DID. However, those who have DID are associated with anxiety and mood symptoms, and they may benefit from pharmacological treatment. Pharmacology treatment for DID include antidepressants and anxiolytics to treat comorbid symptoms, stabilize mood, and reduce intrusive symptoms of hyperarousal and anxiety. Benzodiazepines decrease anxiety. Beta blockers do the same as antidepressants. Atypical antipsychotics stabilize mood and reduce overwhelming anxiety. Prazosin reduces nightmares. Carbamazepine reduces aggression. And naltrexone reduces self-injurious behavior. Although antidepressants and anxiolytic medication are useful in the reduction of depression and anxiety and in the stabilization of mood, there must be caution in using benzodiazepine to reduce anxiety, as it can also exacerbate dissociation. Furthermore, atypical antipsychotics are more effective and better tolerated than typical antipsychotics. Now we will analyze a study conducted on the use of dialectical behavior therapy for the treatment of dissociative identity disorder. The study presented on the slide outlines the case of 30-year-old female, Mariella, suffering from DID, who reported suffering from extensive physical and sexual abuse at a very young age. The treatment team used 4 target levels to guide their treatment. 1. To target multiple nearly lethal suicide attempts and suicidal ideations. 2. To target non-compliance with treatment. 3. To reduce behavior that negatively affects her quality of life, such as substance abuse, depression, etc. And finally, 4. To improve mindfulness, distress tolerance, interpersonal behaviors, and emotional regulation. For 18 months, she was treated with weekly DBT-informed individual psychotherapy, medication management, and initially weekly DBT group skills training. Therapists use various techniques such as validation, safety assessments, mapping alters, guided imagery which creates a safe space, grounding techniques, and more. Each strategy must be tailored to the individual. After 2 years of dialectical behavioral therapy, the patient substantially reduced her frequency of self-harm behaviors, including a 6-week period with no suicidal behaviors, the longest she could ever remember abstaining for. Mariella continued treatment for 4 additional years after the initial treatment mentioned in the study. Treatment was only terminated because she had moved out of the area. Mariella's self-harming and suicidal behaviors had been completely eliminated during the last 3 years of treatment, and she was able to complete goals she made that would make her life worth living. She earned her GED and graduated from beauty school. The authors of the article strongly believe that without DBT treatment, Mariella would not have been able to reach this level of success. Although there has been a lot of success with dialectical behavioral treatment for dissociative identity disorder, there are some factors that could cause criticism for this type of treatment technique. Although switching can be a benefit to the therapist, especially if alters are more concerned for the individual's safety, switches can sometimes interfere with treatment. For example, in Mariella's case, when a therapist attempted to discuss her self-harm of cutting herself, the distress caused the subject to switch to a different identity, Yvette, who berated Marilla's weak character for cutting herself, or Cassie, who had no knowledge of the cutting incidences. This interfered with the therapist's treatment because neither alter could provide details or solutions for an appropriate behavioral analysis. Individuals can also become amnestic when switching, meaning that them or their alters have no recollection of the incidents that occurred and are not able to explain their feelings or reasoning to a therapist. Conclusion. To conclude our presentation on dissociative disorders, we would like to restate a few important facts. These disorders are extremely complex, and there are much more to them than most people may think. It is immensely important to understand the science and biology behind these disorders in order to properly be able to decrease one's symptoms or characteristics. The well-known stigma surrounding dissociative disorders comes mostly from false or over-dramatized portrayal in movies, television, books, social media, and more. Although the current treatment plans for such disorders do not completely diminish every characteristic, the success rate in declining some of the more intense symptoms or behaviors is significant. Individuals with dissociative disorders are not always scary or dangerous, and it is important that they receive the help that they deserve in order to attempt recovery from these debilitating conditions. Thank you for listening to our presentation.